My name is Dr. Betty Vohr, and I am the Medical Director of the Rhode Island Hearing Assessment Program. I have the opportunity to have been in Rhode Island for many years and have been able to witness the odyssey of newborn hearing screening in this state. In 1988, the average age that a child who was deaf or hard of hearing was identified with hearing loss was 2.5 years. And children with lesser degrees of hearing loss, it was not until school age. Well, what was the problem? There was no physiologic method available at that time for detecting hearing loss in newborns. One thing, some hearing loss is not identified at birth, and some is gradually progressive from birth. For instance, there's a virus called cytomegalovirus, which the hearing loss can progress over time, and the infant can, in fact, pass the newborn hearing screen. So in 1988, it was fortunate that a physicist in London, Dr. David Kemp, actually was researching the cochlea of the ear and discovered otoacoustic emissions, the sound waves that elicit from the cochlea in response to a hearing stimulus. And that provided the opportunity to develop a new method for hearing screening. We have made so much progress for infants and children with hearing loss that we know all of the different types of modalities that can be used to make that child's develop language appropriately and able to communicate with the family. The initial recommendation was that newborns be screened by 12 months of age. But with a lot of input from constituents, families, it gradually changed to 1-3-6. And the 1-3-6 refers to the 1 month, 3 months, and 6 months after birth. So the screening is only step number 1. There's a comprehensive team in the state of Rhode Island that makes certain that every baby who does not pass the screen or has a risk factor for hearing loss and pass the screen definitely will have follow-up with a qualified audiologist who is skilled in assessing infants and young children. The diagnostic assessment is critically important because at that point in time, if the child needs some sort of amplification, hearing aids, or cochlear implant, a referral can be made to otolaryngology and to specialized audiologists who can care for that family. Also, if the child is going to be using sign language, the family needs to be aware of it. And the family and the child both need guidance and instruction in how to accomplish this. And that's why step number 3, early intervention, is a key component to this. Studies across the country now have shown that infants identified and receiving early intervention in the 1-3-6, by the time they reach school age, a good proportion of these children are functioning similar to their hearing peers. I'd like to make one other point, that even children with what's called mild minimal hearing loss benefit from hearing aids. Why is that? Because you're actually learning language, and if you're an adult and you're trying to learn Russian or Chinese and you're struggling to hear it just a bit, the subtle sounds, you're going to struggle with it. And so we now know that it's beneficial for all infants to wear hearing aids for at least 8 hours a day so that it will optimize their communication and language outcomes. And we are social beings, humans, and communication is so important, not only within the family, but with peers and community, that we are thrilled that we can now accomplish this in the state of Rhode Island.